In order to understand the causes of aortic stenosis, we need to subclassify the flow across the aortic valve into three anatomical sub-classifications. As you can see, this is the cavity of the left atrium, this is the cavity of the left ventricle, and the blood flows from the left atrium through the mitral valve into the left ventricle, and when the left ventricle it contracts during systole, opens the aortic valve, and the blood flows through the aortic valve into the aorta. Those three anatomical sub-classifications, they are as the following. This is the level of the aortic valve, and what lies beneath the aortic valve is called the subvalvular area, and what lies beyond the aortic valve and above it in the aorta, we call it the supravalvular area. The subvalvular area of notice, it is also called the left ventricle outflow tract. And there are two major entities that happens in this left ventricle outflow tract at the subvalvular area that causes an obstruction of flow towards the aortic valve into the aorta. And those two entities are the hypertrophic cardiomyopathy and the subaortic membrane. The hypertrophic cardiomyopathy will be discussed in a separate lecture, and now we will talk about the subaortic membrane as a cause of subvalvular stenosis. What is the subaortic membrane? The subaortic membrane, it is a fibromuscular membrane that arises from the left ventricle wall and bulges into the cavity of the left ventricle outflow tract, the LVOT. As you can see, this is the muscle left ventricle wall. This is the left atrium. This is the cavity of the left ventricle, and this is the LVOT. The fibromuscular membrane, it bulges from the left ventricle wall towards the cavity of the LVOT in front of the aortic valve. As you can see on the image on the right side, this is a real image. This is the left atrium, this is the left ventricle, this is the ventricle wall, and you can see here this bulging of the fibromuscular membrane in front of the aortic valve level. This is the aortic valve, and this is the aorta. So it bulges in front of the aortic valve at the LVOT or the subvalvular area. This is the membrane. What actually happens when the blood flows through the LVOT towards the aortic valve into the aorta? It faces this membrane. So it hits the membrane and it will face this obstruction, causing an element of obstruction of flow of blood towards the aortic valve and the aorta. What actually also happens, it's not only an element of obstruction. When the blood flows and hits this membrane, there will be turbulence of a flow will be created. You can notice there will be turbulence of flow will be created, and this turbulence flow, it will hit the aortic valve leaflets, and by time this turbulence will cause destruction of the leaflets, and it will result an element of regurgitation. So the subaortic membrane actually results in two entities: an obstruction of flow through the aortic valve causing an element of subvalvular aortic stenosis, and it also causes an element of aortic regurgitation by time from the turbulence flow destructing the aortic leaflets. Regarding the causes at the valvular level, at the what affects the leaflets of the aortic valve, this is called the valvular causes, and you need to be aware of four major causes, which are progressive calcifications, which is the most common, rheumatic aortic stenosis, bicuspid aortic valve pathology, and very rare is the quadricuspid pathology. The calcification is a progressive process that takes time and manifests with aortic stenosis at ages more than 60 years of age. So if a patient presents to you that he is more than 60 years of age with signs and symptoms of aortic stenosis, the most common likely cause is this is progressive aortic valve calcifications. On the other side, if these calcifications happens at earlier ages, we should, at earlier ages that are less than 60 years, in the 40s or 50s, we should think of a bicuspid pathology, as the calcifications tend to occur at earlier ages in those patients. Regarding rheumatic causes of aortic stenosis, be aware that they are almost always associated with mitral valve stenosis, and as we said, quadricuspid is a rare entity. Notice here the image on the right. You can notice the bulky calcifications that are precipitated and invading the valve leaflets here. You can notice those bulky calcifications. Those calcifications actually, they cause limitation of the valve movement, causing an element of obstruction. They don't open and function normally, those valves, anymore. But you can notice here something, that the edges of the leaflets, they are spared and they are not fused together, which is an important clue in your exams and MCQ questions. The mechanism of stenosis in the aortic stenosis, calcified aortic valve, than the rheumatic aortic valve. You can notice here, this is an image of a rheumatic aortic valve. In rheumatic pathology, the leaflets are fused together. This what causes the limitation of the valve leaflet movement and opening. The bulky calcifications causes an obstruction with restricted leaflet movement, sparing the edges, while in rheumatic pathology the leaflets are fused, and that's why they don't function normally, they don't open freely, and element of obstruction happens. Another entity I want you to be aware of it is, sometimes you read aortic sclerosis. So what is aortic sclerosis? What is aortic sclerosis and what is aortic stenosis? Actually, aortic valve sclerosis is the presence of this heavy calcifications across on the valve leaflets, but it does not manifest with signs or the symptoms of aortic stenosis, and does not cause the hemodynamics effects of aortic stenosis. So if there are signs and symptoms and hemodynamics of obstruction through the aortic valve, this is called the aortic stenosis. But the presence of calcifications only, without the manifestations of, what kind of manifestations we are calling, for example, the symptoms of syncope, angina, or heart failure, or the classical ejection systolic murmur of the aortic stenosis that radiates to the carotids. If those hemodynamic effects are not present, this is called an aortic valve sclerosis rather than stenosis. Regarding bicuspid pathology, the bicuspid, you can see here, this is the tri-leaflet normal functioning aortic valve with the right, left, and non-coronary cusps. As you can notice at the image above, that there is only one line of closure rather than this 3 lines. There is only one line of closure that gives you a clue that this could be a mitral valve, an aortic valve, bicuspid aortic valve pathology. What you need to know about bicuspid pathology are the following important points. The first point is that they present earlier at ages. They manifest with aortic stenosis at ages of 40s and 50s. That's one important point. The second one is that they are associated with dilated aortic root and aorta. And the third point, that they are associated with coarctation of aorta. So I need you to think of it like as the following. If a young patient presents to you with uncontrolled hypertension, and by examination you find radiofemoral delay and an element of coarctation of aorta has been diagnosed, what's the next step in your management or in your investigation is to look for a bicuspid aortic valve. And also, if a patient presents with you with a bicuspid pathology and you find that he has a bicuspid aortic valve, you should look for a dilated aortic root, and vice versa. If a patient found to have a dilated aortic root and ascending aorta, you should look for a bicuspid pathology. Regarding the supravalvular causes, what happens above the aortic valve? This is the level of the aortic valve. This is the subvalvular LVOT. This is the supravalvular, and this is here the same. You can notice here that there is element of narrowing, and the element of narrowing above the level of the valve is very obvious, seen here. And this is called the supravalvular aortic stenosis, and these cases are classically present in patients who has Williams syndrome. So Williams syndrome, they are associated with supravalvular stenosis as a cause, and those patients, they have the classical features of blue eyes, the epicanthal folds, the low set ears, the widespread teeth, as you can notice, and the sunken nasal bridge. So whenever you find these classical features, you should think of Williams syndrome, and this is a cause of supravalvular stenosis. Other rare causes is the familial hypercholesterolemia, which it's not important for you to be aware of. Now, regarding the pathophysiology of the aortic stenosis, this is the level of the valve. You can see here, you can see that the blood flows from the left atrium to the left ventricle, and from the left ventricle through the aortic valve. And when the blood flows, the mitral valve is opened during diastole. The flow of blood during diastole from the left atrium to the left ventricle, and during systole, the mitral valve closes and the aortic valve opens. So when there is an obstruction of flow that faces the blood when it is pumped from the left ventricle, what is the first thing to happen to the muscle? The first thing is that you will expect the muscle wall to get more thicker and hypertrophied. So the first effect, there will be a hypertrophy of the left ventricle cavity. I need you to be aware of two entities of hypertrophy that happens in the left ventricle, which are, this is the normal wall thickness, which is almost less than 1.2 centimeter of the left ventricle wall. There are two types of hypertrophy. They are called the concentric hypertrophy and the eccentric hypertrophy. What is concentric and what is eccentric? Actually, in concentric hypertrophy, there will be the muscle fibers will be hypertrophied and in the directions toward the left ventricle cavity. So it will become more thick with a thickness of more than 1.2 centimeter. So what happened to the cavity in concentric hypertrophy? The cavity, it becomes small. It is associated with a small left ventricle cavity size. On the contrary, in eccentric hypertrophy, the wall thickness is maintained at 1.2 centimeter and even less. The muscle is stretched due to causes that causes stretching of the muscles. And the left ventricle cavity in eccentric hypertrophy is large. What are the causes of concentric hypertrophy? We are talking about aortic stenosis, and be aware of hypertension. Regarding the eccentric causes, examples like the dilated cardiomyopathy and the aortic regurgitation, where the blood fills the left ventricle more, causing stretching of the muscle fibers, causing an element of eccentric hypertrophy. Let's go back to the pathophysiology. So the muscle has hypertrophied, concentric hypertrophy has developed. What do you expect the pressure inside the ventricle to happen? To the pressure inside the ventricle, the pressure will be increase in the pressure. I want you to memorize this with me, actually. And it's very important for you in order to understand the mechanism of edema and the valvular effects, whatever the valve. You need to understand this, the normal physiology in order to understand the abnormal. You know that the ventricle fills during diastole, and its maximum filling, it happens during end diastole. So the pressure that is built in at the end diastole is called the left ventricle end diastolic pressure. Please concentrate with me, this is important. The left ventricle end diastolic pressure, when the mitral valve is opened, fully opened at end diastole, this pressure inside the left ventricle will equal the pressure inside the left atrium. So the left ventricle end diastolic pressure equals the left atrial pressure. And this pressure is reflected back to the pulmonary veins, called the pulmonary vein pressure, which is reflected back to the pulmonary capillary bed, which is called the pulmonary capillary wedge pressure. This is the normal pressure in normal subject. You need to understand this. So what happens with aortic stenosis is that the pressure has built up. There will be an increase in the left ventricle end diastolic pressure. So this will increase as the mitral valve is normal and functioning normal and it's opened at end diastole. So the pulmonary capillary wedge pressure, this pressure will be reflected all the way back to the pulmonary capillaries, and at the end the pulmonary capillary wedge pressure will be elevated, and at this moment there will start to be leakage of fluid into the alveoli, and at this moment the aortic stenosis start to manifest with shortness of breath as part of congestion from the pulmonary congestion and edema.